Hello everybody, it's lovely to see you. What a lot of people are here. That's absolutely marvellous. My name is Ruth Gardner. My background is social work and managing social work in inner London and also research, most recently with University of East Anglia on serious case reviews, which is how I got really interested in the neglect of children. I'm going to talk today about the work I've done leading the theme of neglect at NSPCC over the last 3 years. We now have a new theme lead, Chris Cuthbert, and he's taking the theme forward. But I'm going to discuss the programme we've done, including some new research evidence around neglect, both that we've funded and funded elsewhere, the principles and the strategy and the content of the work we've done. And I'm going to pose some questions. So that's the content. I'll be going through it quite briskly, but you will have the slides, so if I don't cover every single point, don't worry, I can follow up later in questions. I'd just like to say that this is intended all to be relevant, even though it's taking a step back, if you like. It's one perspective, it's the learning curve that we've been on, with at least 40 local authority partners, including some in Wales. And you've done a huge amount to help us learn in the course of this, so this is one way of sort of bringing some of that back. But obviously there's huge experience in the room from other voluntaries and from you in local authorities and other agencies. They say there's two things you shouldn't see made. One is sausages and the other is the law. Well, I can add a third, and that's new practice. It's very hard. It's very messy, and it doesn't necessarily always turn out the shape you'd hoped it would. But one thing you do already have here is a commitment to tackling neglect as a priority. You've already got some terrific work underway to raise awareness and skills evidence today with all you coming here. You've got some preventive interventions such as Flying Start and Families First, and some really interesting findings around the evaluation of Flying Start about measurable positive changes in parenting and an enthusiasm for multi-agency working. So we shouldn't always be thinking about the huge stresses, even though they're so important, about neglect. We should really point at our achievements and what they are and congratulate ourselves. We have research into neglect in Wales, which you're going to hear about later, which is a real collaboration between voluntaries and government and statutories. And we also have greater levels of evidence on the effects of neglect. And I'd point you to Core Information, which is at the back of the room, marvellous initiative which Aideen Norton has been very closely involved in, and we're very proud to be funding partners for that. We published the evidence around the effects of emotional neglect and abuse in preschool children, and we're about to publish later this year the same but for older children, 6 to 14. So that's really important work that's beginning to start to make our understanding of neglect more scientific, and that's so important. So some steps on the way on this learning curve that we're all engaged in. We need to understand the impact of neglect, and Jan's doing some wonderful work around that in terms of how the child actually feels and experiences neglect. The impact on the family of being in that situation and the impact on practitioners. We need to be able to recognise the signs and symptoms more clearly, and they're not always obvious. One study shows that children who watch television under 2 years old for more than 4 hours a day indicates that there's more likelihood of them being physically neglected later in their lives. And primary school teachers tell us that children who can't engage with eye contact, they can often tell that those are the very children who've been stuck in front of a television every day. It's those early signs that some people can start to see something's wrong that needs to be checked out, and we need to gather together that kind of intelligence. Understanding child development, normal child development, is absolutely crucial, and we need to demand better training and more training on that. And each child's development, what should this child be doing now? Ways of demonstrating what good parenting looks like, because very often parents simply don't know. I remember hearing a health visitor who'd given out lots of toothbrushes and toothpaste free to a family and had come back they weren't used. The parents didn't know what a toothbrush was. So we have to understand what good parenting looks like and be able to go through that in very great detail for families. We need to share assessments at the very start of cases, in progress and in follow-up, so that we're communicating better what it is we're seeing. And we need to aim for evidence-based intervention with a much more clear recording of observations and measures of progress. Why? Very often practitioners feel hemmed in by using measures, because without that kind of evidence, we don't know if we have changed this child's life. We may feel it, everyone may be very happy, but we haven't actually got anything to tell us concretely what is the difference between then and now. And we don't know why. We don't know how we've changed them or why we've changed it. So we need those records. And secondly, Jan was talking about cumulative harm. We must communicate, including with the family, and record our concerns. We're very, very worried about privacy and confidentiality, but very, very often if we discuss that with the family, they will agree to sharing. And there are overrides to that concern if we think this child may be suffering or likely to suffer harm. So we have to be prepared to share concerns and to record them, because with neglect, it's very often that accretion of quite small, low-level concerns, frequent, low-impact harm, that is the damage. We worry about definitions of neglect, and rightly so, but very often we don't think about what we're actually asking parents to live up to, and it's a tall order. There's this rather unhelpful definition from the law, which simply says all the rights, powers, responsibility which a parent has. There's another which says that what parents do, the behaviours necessary to achieve the objective of the child becoming autonomous, help them to grow up and have aims of their own in life. And then there's this definition that breaks it down, as I think Scottish law does, into a duty to maintain the child, to provide safety, emotional and physical care, support education and pro-social behaviour. And Henriksen adds that the parent who's actually with the child is the one who's likely to be accused of neglect. A parent who's actually disappeared and perhaps left the family feeling neglected may not be accused of the neglect. We need to debate and be clearer about what we expect from parents before we tell them they're not fulfilling those expectations, and be able to explain that and the reasons for it clearly. The criminal law also states that parents have a duty to seek support and help. So that's an area that we need to look at more closely, and sometimes it eludes us, I think. As Jan said, neglect affects a cross-section of children. It's not only about deprivation. And there's an interesting study on the Avon longitudinal study on a huge population showing that it's more about characteristics of families where accidents happen to children than it is about characteristics of neighbourhoods. Younger parents, parents without work, parents who smoke, parents who have difficult relationships. And of course that may be associated with deprivation, but it's not the same thing. So one example of what I'm saying is a health visitor who told me she'd made her first visit to a beautiful home, absolutely pristine, white carpets, and she saw a row of lit candles in the hearth, decorative candles, and because she was a little bit concerned, she said, "So where does your child play?" And it turned out this little girl was actually kept in a pushchair all the time, and this had happened so continuously that her skull had become misshapen. But because that health visitor on a first visit was willing to ask the question, she was able to get help. Another example in the press recently, and we get quite regular examples of criminal neglect in the press, was a 14-year-old dying of drug use with her friends hospitalised because the parent had left drugs completely available in the home, and he was a university teacher, I think. So those are areas where this idea of parental responsibility goes beyond just deprivation itself. And a drugs worker said to me that when she saw real squalor, feces on the floor, food rotting in the fridge, beds urine-soaked, she felt that was always about more than deprivation, that there were always deep underlying problems there that needed to be sorted out. So deprivation definitely is a chronic stressor and we must alleviate it, but it's not the cause of neglect any more than we would say it was the cause of physical abuse or sexual abuse. The problem with neglect, we undertook a survey with Community Care in 2012 and 250 respondents across all the professions. Less than 1 in 10 of those was confident that timely action would be taken on neglect and emotional abuse, while over 70% were confident about other forms of harm. Most thought that parents' needs would take precedence, as Jan was saying, that there were insufficient services and resources, insufficient attention to whether the parent could change or not, just sort of blindly going forward trying to help, and very much unsure that court cases were heard in a timely way because of the way evidence was provided. And a more recent survey finds that thresholds are rising on neglect in the perception of professionals more than with other forms of maltreatment. So when the pressure's on, when the heat's on, it's the neglect cases that tend to fall out of the folder in terms of supervision and concern. And it takes real concerted effort and joint working to kind of resist those pressures. One particular concern is that wherever the threshold is, in terms of intervention, we may need to act straight away, not, to take too much notice, indeed, of the guidance or the thresholds, but to say something must happen now. One example, this is from a paediatrician, is about failures to attend. For a child, because they're growing, because they're developing, if they have a condition that needs attention, then they need it straight away. And these failures to attend, each one causes a dip, a deterioration, until the child may actually have a permanent concern or condition that they didn't have before. One example was a child left in a cast having broken their arm for a year. So after a year in this cast, without ever attending hospital, his joint was distorted permanently. Another example, a serious case review I read, was a child with epilepsy who had never had her medication, even though that medication was free, and as a result, in her early teens, she died in a fit. So those things which, again, they're sort of continuous and low level until they result in a crisis for a particular child. I'm going to just talk briefly about some research not funded by NSPCC, but it's really interesting, by Harriet Ward at Loughborough University. This is a group of babies identified as suffering or likely to suffer significant harm before they were born, and certainly before their first birthday in the other cases. Most of that significant harm was neglect, and a lot of parents had substance or alcohol abuse problems. They've been followed until they were 5, and you can see that 37 out of the 57 are still being followed. And this was the kind of evidence that was collected. By age 1, they all but one were thought likely to suffer significant harm. So by age 3, 37, over a third of those babies were adequately safeguarded. They were with their birth parents and they'd sustained positive changes. So that's really good news. Given the doubtful start for these children, a lot of work put in. If they hadn't started to make those changes by the time the baby was 6 months old, they were unlikely to make them. Another third were permanently separated. But, and this is where it gets worrying, nearly a third were inadequately safeguarded and the parents hadn't changed. They hadn't shown ability to change. Half had experienced abuse or neglect while being supervised. Over half had been maltreated while the case was open, and over half were displaying emotional problems or substantial behavioural problems by age 3. By age 5, nobody died, but their development and long-term well-being had been compromised, and there were children in the sample who were not being fed for so long that they'd given up and ceased to cry, could explain how to prepare heroin, were left to forage in the bin, were so dirty the school had to wash their clothes. That's an example of services trying to compensate so that actually the symptoms of the neglect don't appear, were so dirty, as I said, that the school had to wash clothes, and had grossly inadequate communication. And then the last couple of points shows just how long it took to take decisions. So for 2 years, no permanence decisions were able to be taken, which argues that very, very early on we need to set very, very specific targets, we need to look at what that child is actually experiencing if those targets aren't being met, and we need to be able to describe that very, very clearly against developmental aims for the child. This is some work that NSPCC did fund and was published last year by Marion Brandon and colleagues at UEA, and it was looking at the whole sample over many years of serious case reviews for Department for Education. These findings apply to England, but I can tell you, having read Welsh serious case reviews and from other countries, that they're very, very relevant. And she was looking at all the neglect elements of those cases. And the first question was a quantitative one: how often was neglect evident? So in the biggest sample, the 645, there were child protection plans for 1 in 6 cases on neglect, and that was more than all the other types of plan combined. So where a child died or was seriously injured, the number of children who were actually being supervised because of concerns around neglect was higher than for all other types of harm combined. And as you can see in the bottom point, good news was that children who died or were seriously injured while on a plan, those numbers have slowly gone down. So it looks like plans actually are a sign of really close monitoring. But when they come off plans, there is no reduction in cases. So that might ask us a question about safety nets and step-down services. And I'm really glad to hear that your Families First service does provide that. It's a real issue that children come off plans and there's nothing there for them in the way of support services in the community. So summing up that research, 60% of the more detailed cases that they looked at from 09 to 11, 6 out of 10 were neglect cases. Neglect hadn't been formally recognised in the way of a plan, but when they looked into the cases, it was there throughout. And it was evenly across all age ranges, but over 18 in 10 of the adolescent cases were neglect cases, and that's a real wake-up call, I think. And most of those cases were suicides or attempted suicides. There was chronic neglect throughout those children's lives, and nothing had succeeded in stemming it until the tragic outcome. And these were the themes in the cases, which I think are really useful. The study itself is worth reading. It's very well written, and it's got case examples for each of these areas. And I'd just like to point out accidents. We talked about accidents earlier. Very often the reports would start with, this was an accident waiting to happen, or this was a tragic accident. Again, if you looked at the chronology, you could see that there had been many, many serious accidents in the families' lives, burnings, children run over, all kinds of things that should not have happened. And yet it had only really come to light at the end of the day. And that's why I think this consistent recording and the need to really communicate concerns is so important. I won't go through this study. I'll move on to the work we're doing because you're going to have some really good studies later. But that's a compilation showing this accretion of concerns throughout a child's life until, sadly, there was a suicide at the end of it. And at any one of those ages, something could have been done, perhaps, that would have changed that sequence of events. I'm going instead to move on for the end of my time to a bit of a happier note, which is our struggle with the sausage-making machine, if you like, of trying to turn practice around and do things a bit differently. This was the kind of strategic model that NSPCC took up, and we started off at the top left back in 2010, where it said focus, to scope the research, to scope practice out there, to see what good news there was in terms of evidence. And there's not a great deal around neglect, I have to say, and what the research questions should be in terms of changing practice. Then we chose particular pieces of work, each theme, the under ones theme, the physical abuse theme. We simply divided up the field of maltreatment into manageable chunks, if you like, with neglect, and then we decided to test these approaches. And currently we're at the point of evaluation results starting to come through after 2-3 years, and deciding whether to promote these activities. This hasn't been a commercial venture, it's been like a learning exchange venture, and it will continue to be like that for the foreseeable future. And we're at the point of now seeking partners to test these further and see whether they work in different situations and transport across the UK. The aims, the principles for the theme, were to make neglected children more visible and more heard. As Jan said, they tend not to be there. They tend to be wallpaper in all of this. We discuss them, we write about them, but we don't hear them. I'd recommend to you a really good study by Gwitha Rees et al., Adolescent Neglect. If you're going to read one book, apart from Jan's, about neglect, that's a really good one because it has many, many quotes from young people in it, and they come alive through the pages. Now, there's a quote from a young person saying, "I feel like a ghost in my own home. I don't feel as though I exist for my family." And it really shows you that young people can express what it feels like if they're given the opportunity. We want to help communities and services. We want to find and test programs, which I'll talk about a bit, and raise the profile of neglect. Safe care. Safe care is a well-evidenced approach, a parenting program. It lasts around 5 months, but it can be repeated and it's extended if necessary. It originates in the States, and it has 3 modules. It's been developed with practitioners over decades, 2 to 3 decades. They are home safety, where the worker actually goes around the home with the family into each nook and cranny and says, is this home safe? Is it child-friendly? And works on that with the parent. Child health, so the parent can take action if there are concerns about the child, and learning what the child's developmental age and stage should look like, and parent-child interaction, working on play, on discipline, and so on. Our findings are beginning to see, very early, measurable and sustained improvements in home safety. So the parent's getting it in terms of the fact that it's not good for the child to be in a room that has some kind of dangerous equipment in it, say, or sleeping very often in a room where the bed is covered in bin bags, those kind of examples. And they're beginning to take pride in making a difference to the home. So our staff have been trained, and currently we are looking to train other people because we have our own trainers now. We've reached that point. So I'll go into the evidence a little bit later, but I'll move on swiftly. Another example is video interaction guidance, which you may have heard of. There's good evidence that use of video strengthens family programs because the parents can actually see the change. They can see what they were doing. Very often it was not evident to them that they never looked at the child when they spoke to the child, or that they were always scowling at the child when they put food in front of the child, or that they shouted. There's good evidence that communication from parents to children, where the child shows signs of neglect, very often the communication is either shouted, commands, or it's questions. Why aren't you doing that? It's not a communication that's a two-way conversation, inviting an interaction. So we're delivering the program for 2 to 12-year-olds, and the practitioners are trained technically to use film, but also to edit it so that they get a clip of a good interaction. It could just be eye contact. It's quite skilled to find a good interaction, and then to build on that and help the parent work with it. And the workers absolutely love it. They've transported it into other work they do, because not only can they see the parent seeing change and making a change in the way they behave to the child, but they themselves can see their own practice. And these kind of differences is what we want to see. That not as something that occasionally happens. Obviously, parents are not always involved with the child, but as a change in the whole relationship. And we've had parents say that they thought their child didn't love them. Surprisingly, really, that we didn't think they loved their child, but the parent is saying, I didn't think my 6-year-old loved me, I thought he hated me, and I've only just realised that he smiled at me when he went to bed. I hadn't seen him smile before until I saw the video. It's actually really moving stuff when you see it. So on to assessment quickly. This is working together, which has added at the bottom some stuff around neglect, saying that there needs to be rigour in assessing and monitoring children at risk of neglect, and there should be decisive action where existing interventions are insufficient. It's easy to say that. It's much, much more difficult to follow, but it does require us to assess neglect in a way more rigorously and in a more measured way than we have hitherto. And we're using here in Wales, something called evidence-based decisions, an assessment tool called the North Carolina Family Assessment Scale. There are many, many tools, and they all have virtues. This one has the virtue that it's well tested in the US, and we've adapted it for the UK. We work alongside local authority workers, and we do 2 to 3 visits at time 1 and the same at time 2, conducting a family functioning review. That's what we call it. The North Carolina scale allows you to rate strengths and difficulties for the family so that they can see where they have good progress and where they can build on things, and it's positive in that sense, and you can specify very clearly where you need to put the resources. And we're learning and working on how it informs decision making, and the early feedback is that people feel it's not an easy process, but that yes, it does help them to start to see more clearly where the family is, what needs to change and whether it can change. And you can aggregate it across cases. These are the domains it covers. 8 domains. The environment, the social and physical environment, parental capabilities, family interactions, and each of these are broken down so that family safety would include the safety of the home, child protection, access to the internet, those kinds of things. And on each of those you scale so that 0 would mean you don't require to intervene, you could intervene, but you don't have to. +3 would be a clear strength, so say family interactions were good, there was interaction across the family, but family health was very poor. You could see that very clearly, and indeed they're colour-coded in some of the reports we write. So we provide a report to the local authority on the results. And the worker then, from the local authority, has those skills, has the tool, and can use them again if they want to. We're evaluating the graded care profile, and the Department for Education selected 2 promising safeguarding assessment tools. One was based on the Common Assessment Framework, and the other was the graded care profile. And they put on their website that NSPCC's UK evaluation would provide the results about whether to carry this forward. The graded care profile, again, was devised in this country over decades by a GP, now a paediatrician, and it measures with the individual child. So it has the virtue, as Jan said, of looking at this child now. You'd do 4 if there were 4 children. And the domains for that are physical care, safety, love, and esteem. It shows whether the parent is committed to that child sufficient to make sure those areas are well attended to in terms of the child's welfare. So it can show very clearly what type of needs exist. There could be lots of love, very well-loved child, but for some reason the physical care is poor, or vice versa. It literally gives you a visual profile, and it's very, very clear for the family then what needs to change as well. It gives you a baseline and a follow-up, distance travelled, as with the North Carolina scale, over time. And it supports professional judgment. That's the key thing. It doesn't replace it. It's not a tick box, but it helps in this very, very muzzy field where what you think neglect, I might not. It helps you actually share in a case conference, well, I think it's this serious, and I think this is the evidence why. We've got evidence that in England, the estimated cost benefit for safe care is 2.7 to 1. So that means for every £1 spent, we should save £2.7. Now, whether that will work or not, we don't know, but we'd like to test that out. We'd like to see against not using it or using ordinary parenting support, whether it actually does have that focus that it gets the right areas of concern sorted. It also, there's been a huge RCT in Oklahoma, and it has achieved a marked reduction in re-referrals there, including with neglect cases. With video interaction guidance, as I've said, there's evidence that it improves the parent's sensitivity to the child, and on measures of child development, things are improving too. And that's what we want to test in rolling it out, because definitely our workers are enthusiastic about it, but we have to test it in different circumstances. We're seeing in our own evaluation reported reductions in children's difficulties using pathways PPP and VIG, that's from the parent and the child. Again, we need larger scale tests. And with both the assessment tools we're testing, professionals interviewed independently say that yes, it does help inform their judgments, but this doesn't make it any more difficult in many ways to test across wider populations and to find out what circumstances these things work best in, and that's what we want to do next. But we are learning, we are moving on. So I'll leave it there, but I had asked to put a few questions forward, and these are mine. How do we raise our skills and confidence in assessing neglect? We have some tools. Hopefully we would have training and continuous training. You just can't hand these tools out and let people get on with it. There has to be shared understanding. So the practitioners inform the development of the tool, which is what we're trying to do. You actually improve the tools as you improve practice. What kind of support is best? Despite the evidence that very clearly says neglect needs to be treated as much urgently as other categories of maltreatment, why does it still seem a lower priority? Why do people say they're under pressure to downgrade cases, and how do we change that? Because we can see that the damage is just as great as with other forms of harm, and indeed very often includes those other forms of harm. What changes would you like to see? And in a wonderful world where we had the funds, what would your priorities be? So those are my thoughts for the day. Thank you very much.